Hello, everyone.
Hello.
Hi, welcome everybody to our second Healthy Smile, Happy Child Telehealth, actually just presentation series now. My name is Daniela Demery. I'm the coordinator for Healthy Smile, Happy Child. I'd like to thank you for joining us, and I know we've got some people coming in by telehealth and some by Zoom. Just for the telehealth, if I could do a roll call with telehealth and see who's here and how many people are in your room. I won't do the same for Zoom. So just right now, if we have Churchill, if you could say hi and tell us how many people.
Hi. It's just one.
One, okay. And Flin Flon?
Hi, it's just one right now as well.
Okay. And Hollow Water? Okay, and Thompson? The Grace Hospital?
Oh, hi, Thompson, we have 5 here.
Oh, Thompson 5?
Yep.
And Grace Hospital? Or Winnipeg Access? Is Access Winnipeg West there? No? And Grace is not there?
Grace is there.
Yes, we're here. Access Winnipeg West, there's going to be 2 of us.
2? Okay.
Oh, that is at the Grace.
Oh, that is that. That's at the Grace?
That's great.
Okay.
Yeah, we're the same.
Okay. And then Hollow Water is still not there? So we'll just go ahead. And so if you've received our email this morning, we sent you a feedback form and a participation list. If you could fill them both out and send them back to us. And if anybody wants CE credit for the presentation, just let us know on your participation list. And for anybody that's on Zoom that we weren't able to access via email, if you want to give us an email back, then we can send you the participation list and the feedback form as well. But I won't take any more time, and we'll get started with Dr. Robert Schrodt.
Sure. So I have the pleasure of introducing Tara Kennedy. She is currently a third-year pediatric dentistry resident at the University of Manitoba with a program based out of Children's Hospital. And Tara is working on a great project looking at body mass index and its association with severe early childhood caries. A little bit of background about Tara. So she's a native of Ontario. Had a background in foods and nutrition before studying dentistry at Western University in London, Ontario, and then did a hospital pediatric dentistry internship at the IWK Health Center in Halifax before coming to Winnipeg. And we're excited as well. She has great news that after she's finished her residency next spring, she'll be off to Australia doing a clinical fellowship there. So Tara will turn it over to you. But we could maybe ask everybody, just maybe mute yourselves for now, and Tara will be taking sort of breaks in between her talk to see if there's questions from viewers. Thanks.
Great, thank you so much for the introduction and for everyone being here this morning. I'll try my best to talk at a reasonable pace. I have a tendency to get a little nervous and get ahead of myself, so I'll try to keep it at a slower pace, but as Dr. Schrodt mentioned, today I'm talking about the association of body mass index and severe early childhood caries in young children. There's a lot of information to cover, so I will take breaks, and please feel free to ask questions as we go. So a little bit of an outline of what we'll touch on today. I'll review some of the background information on early childhood caries and body mass index. A little bit about my thesis research and what brought us to this presentation today, as well as some of our major results, our conclusions and some of the limitations and plans for further study analysis, as well as some key education points that you can take home and share with other people. So dental caries is actually the most common chronic disease in children. In children under 72 months of age, early childhood caries, or ECC, is defined as one or more decayed, whether it's cavitated or non-cavitated, missing due to caries, or filled tooth surfaces. So this is quantified by calculating the DMFT score, which is the number of decayed, missing, or filled tooth surfaces, or teeth, sorry, or DMFS, which is decayed, missing, or filled tooth surfaces. And they're indices that can range from 0 to 20 in terms of teeth, or 0 to 84 if you're referring to the number of surfaces in a child's mouth. Instead of the term rampant caries or baby bottle tooth decay, the term severe early childhood caries is used by the American Academy of Pediatric Dentistry to describe any sign of caries on a smooth surface in children under the age of 3, any smooth surface on the primary tooth, either in the front or the back, that's decayed, missing, or filled in children between the ages of 3 to 5, and a DMFT index equal to or greater than 4 at the age of 3, 5 at the age of 4, and 6 at the age of 5. It's well known that if left untreated, dental decay is a disease that can progress rapidly and can impact both the immediate and long-term quality of life of children and their families. Consequences of dental caries can include an increased risk for developing new caries, development of dental infections and abscesses that can lead to emergency room visits and eventual hospitalizations. It can also cause pain, alter a child's eating habits, cause sleep disturbances, and changes in their overall behavior. Unfortunately, due to the young age of a lot of these patients and the extensive treatment needed, general anesthesia is often required to provide dental rehabilitation. Pediatric dental surgery has actually become one of the most common routine day surgery procedures in Canada because of this. The World Health Organization has defined growth as the single best measure for defining overall health and nutritional well-being in children. Body mass index, or BMI, is a measure of weight adjusted for height and can be used to evaluate an individual's body weight relative to population norms, or growth charts. It's measured taking the weight in kilograms divided by the square of their height in meters. Now, depending on the country where you live in, it determines the organization you refer to. So in Canada, we typically refer to the World Health Organization, which I often will say WHO instead of World Health Organization. They have 2 growth chart recommendations: the WHO growth chart standards for birth to age 5, as well as the Growth 2007 reference for children aged 5 to 19 years of age. In the United States, they refer to the Center of Disease Control and Prevention, or CDC, recommendations for children and teens aged 2 to 20. BMI Z-scores are actually a BMI standard deviation score that have been adjusted for the child's age and sex. The BMI Z-score and Z-score percentiles can be used to directly compare to the growth chart references. Because Z-scores are calculated based on an external reference like the WHO or CDC growth charts, the calculated Z-scores and percentiles do differ slightly. So both WHO and CDC have generated parameters for BMI for age classifications based on their corresponding growth chart percentiles. I've created this chart so it's easier to see the comparisons of the percentile distributions with each growth reference. The WHO Child Growth Standards and the WHO Reference 2007 distribute percentiles into 5 categories. For birth to age 5, they include an at-risk of overweight category, whereas in the WHO reference, they include a severe obesity category. The CDC, on the other hand, distributes percentiles into 4 categories of underweight, healthy, overweight, and obese. For the purpose of this presentation, I'll focus mainly on WHO data just because we're in Canada. So what do we know to date? There's been multiple studies in the past that have looked into the relationship between dental caries and body weight, but more specifically obesity. It has been well reported that childhood obesity is a growing problem in developed countries like Canada and the United States. We know that frequent consumption of carbohydrates, specifically those that are simple sugars that we find in a lot of our sweets, snack foods, and juices, they have a strong association with dental caries and obesity. Although both of these diseases are multifactorial in development and are the result of so much more than just our diet. A study recently published by Davidson et al. In 2016 actually showed that children in Manitoba that had severe early childhood caries were more likely to be overweight or obese compared to caries-free children of the same age. Other studies, however, have reported a negative association between body mass index and severe early childhood caries, with the presence of severe early childhood caries being found to be associated with failure to thrive, malnutrition, and an overall lower BMI. Multiple studies have reported there's actually no significant association between childhood obesity and caries, or BMI values that only border on the edge of the healthy normal range, including a recent systematic review and meta-analysis from Hayden et al. In 2013 that reported there was no association between obesity and caries in the primary dentition, but the possibility of a very small association between obesity in the permanent dentition. These differences in these findings could be related to the location that the study took place, variations in those populations, or could suggest a relationship between caries and BMI Z-score that reflects a J-shaped or U-shaped association, where we actually have an increased relationship happening on both ends, so with kids that are overweight and underweight having severe caries. So while we do know there's differences in reports in the relationship between BMI and dental caries, it's well known that there are multiple factors that put individuals at risk at both types of these growth problems. These generally include genetics, socioeconomic status, cultural influences, dietary choices, environmental factors, and lifestyle. And in Canada specifically, it's been well documented that compared to the general population, Canadians of lower socioeconomic status, of Indigenous status, or lacking dental insurance tend to have poorer oral health. Similarly, an increased risk of obesity has been associated with population groups of lower income, Canadian Indigenous status, and with food insecurity playing a major role. So I know that's a lot of information just to start things off, but if anyone had any questions before I keep moving on. Right, working on the computer side of things.
Yeah, if there's any typed in questions.
I don't think so. We're working on the computer. My apologies. Yeah. Oh, just gotta find the audio.
Oh, yeah.
Okay.
Okay. So no.
No.
Okay. So we keep moving.
It's good?
Yeah.
Okay.
Perfect.
Sure.
Okay.
Perfect. So this brings us to my study. And the purpose of the study was to evaluate the association of body mass index and Caries scores of preschool children undergoing general anesthetic for rehabilitative dental surgery. This is actually part of a larger research project being done here, investigating the changes in nutritional status of preschool-age children affected by severe early childhood caries following dental surgery, specifically looking at their iron status and vitamin D levels. So the hypothesis of this study is that there is an association between body mass index and Caries score in young children. And the primary objective of the study is to evaluate the relationships between BMI and severity of severe early childhood caries in children undergoing general anesthesia for dental surgery in Winnipeg, Manitoba. Secondarily, we're hoping to look at the association of the number of pulp-involved teeth or abscess teeth. So for those of you that are unfamiliar, pulp-involved just means the cavity extends into the nerve of the tooth. Or abscess means the tooth has an infection, and whether that has an impact on the body mass index score that we see in children, as well as having the need for anterior, so front or back, extractions in the mouth, if that plays a role in our body mass index. So children were recruited, as I said, as part of the larger study, changes in nutritional status and well-being following dental surgery to treat severe early childhood caries. And recruitment occurred at the Misericordia Hospital in Winnipeg, where children were being seen for the dental surgery. Consent was obtained from their caregivers, and participants were asked to complete a questionnaire about their social background and dietary intake. Preoperative measurements of height and weight were taken using a calibrated detecto-prodox scale and stadiometer. And a $15 honorarium in book to promote child and family literacy was provided at the recruitment day and also at a 3-month follow-up visit. We use the Canadian Pediatric Endocrine Group Shiny apps, which are online anthropometric calculators that can be used to calculate BMI, BMI Z-score, and BMI Z-score percentiles for both the WHO and CDC growth references. Primary comparisons were made with the WHO growth charts for Canada, as the target audience is Canadian. However, some CDC data will be used to compare to studies in Manitoba that previously reported on BMI and DMFT and DMFS scores using those references. A retrospective review of all dental charts and operative reports of participants was done to calculate DMFT and DMFS scores based on treatment rendered. So this means that any tooth that received a MO, which is a tooth surface filling, for example, contributed 2 to the DMFS score. Any tooth that received a stainless steel crown, which is a silver cap that covers the entirety of the tooth, is treated as 5 surfaces. We also took note of the number of pulpotomy treatments. So again, that's basically a baby root canal treatment on a tooth involving the nerve, rendered in addition to the number of extractions and where they were in the mouth. Our target population included children under 72 months of age, or 6 years, those receiving dental treatment for severe early childhood caries, and any children residing in Winnipeg or close to the city. Participants were excluded if they were undergoing surgery for something other than severe early childhood caries, or if they had other existing comorbidities or chronic disease, aside from obesity. So 150 children with severe early childhood caries were recruited, and we were able to obtain operative reports for 147 of those participants. The average age was nearly 4 years old, with approximately the same number of males and females. And majority of the patients did reside in Winnipeg. The graph on the right-hand side shows the age distribution of children in our study. You might note that some of these ages actually fall beyond the age range of 72 months. And that's because we elected to include these participants in our study because they were diagnosed with severe early childhood caries while they were under the age of 72 months and unfortunately had to wait for their dental surgery due to long waitlist times. We were able to obtain socioeconomic data for 149 of our participants. Just over half of them came from a family with an annual income of less than $28,000 per year, with an additional 16 families reporting they were unsure of what their income was. And over half of the participant families relied on some form of government assistance, with over 90% of them recognizing that they did have some support in terms of dental insurance for their child, whether it be from social assistance, federal non-insured health benefits, or private. Here you can see the distribution of the DMFS surfaces score. We use surfaces rather than teeth as a marker because we could see a wider distribution of the data. And while patients ranged with DMFS scores between 5 and 84, boys were found to have a significantly higher average DMFS score than girls. When we categorize based on the WHO BMI classifications, we can see that the distribution of our participants, and while the majority of the participants were classified as healthy, that's the red area in the pie chart, with a mean BMI of 16.8, it's valuable to note that 42% of the participants were classified as at risk of overweight, obese, or severe obesity. There is no significant difference noted between sex, which makes sense because BMI scores should be corrected for age and sex in this case. Now, I referred to Davidson et al. Study previously in Manitoba. They studied children from 2009 to 2011, and their population included children both with and without dental caries. And they used CDC growth references to classify their findings. So I recategorized our data with CDC findings or growth charts and found when we compare them from plotting it against the previous study, our distribution is actually quite similar. A large portion in our case is 36.7% and 34.4% in Davidson's study of the sample. They fall into categories of overweight or obese. This graph compares the percentages per group of participants that were categorized as overweight or obese on CDC references, but comparing the caries-free children in the previous study as well as the children that had severe early childhood caries. And while the percentage of participants in the range of overweight and obese are not quite as high in our study as they were in Davidson's study, the comparison could suggest that children in our study are also more likely to be overweight in comparison to children of the same age that are caries-free. So is everyone still with me? That was a lot of numbers. Any questions? I don't see any raised hands. I don't see anything on here. How did you look at that again? Yeah, no questions there. Okay. So back to our results, we ran some correlation analyses and found that there was a slight positive relationship between body mass Z-score and DMFS, which was statistically significant. So an increasing Caries score was weakly associated with an increasing Z-score. We also found a similar correlation between the need for anterior extraction, so having the front teeth removed, which was slightly positive and also statistically significant. So kids that needed more teeth removed tended to have a higher BMI Z-score. And perhaps surprisingly, we saw a slight negative relationship found between posterior extraction, so having molars removed in the back, with a BMI Z-score. So having more teeth removed in the back of our mouth resulted in a lower BMI Z-score. So more numbers again, I apologize, these are quite dense slides. But a closer look at our body mass index, we found that age was actually slightly negatively correlated. Children from families with a yearly income of less than $28,000 a year were had significantly higher body mass index scores. And parent level of education was also slightly negatively associated with the body mass index score. So those with a higher education correlated with a lower BMI. Just for reference, the definitions we used for education was did not finish high school, made it to grade 12, completed some post-secondary school, finished post-secondary school, or they declined to answer. And as it's been reported before, lower socioeconomic status is associated with higher obesity and it's been well documented in the literature, as has parent level of education, which in this case showed the slight negative correlation, which was significant. Looking at variables linked with DMFS score, age was not significantly correlated. However, boys did seem to have a significantly higher average of DMFS score than girls. Children from families with a yearly income of less than $28,000 had a higher average Caries score, although it was not significant. Parents' level of education was found to be slightly negatively correlated with Caries score, which was significant. And not surprisingly, the number of anterior extractions and posterior extractions were significantly and positively correlated with Caries score, as you would expect to have a higher Caries score if you're needing to remove more teeth. So a number of our participants were identified as registered First Nation status. This variable alone was strongly associated with other co-variables being evaluated in this study. Children of First Nation status had significantly higher BMI Z scores compared to the other participants, as well as higher DMFS scores. These individuals also had a significantly higher number of pulp involved, so those teeth that had caries extending into the nerve, and a significantly higher number of anterior extractions. But there was no difference noted in the number of posterior extractions. So our initial analysis suggests that the majority of children with severe early childhood caries that are undergoing dental surgery in Manitoba have a healthy BMI, which is good. That said, a large portion, 42% of these patients, are categorized into suggestively unhealthy ranges based on home growth charts. Individuals with First Nation status have significantly higher BMI Z score at the time of surgery than all other participants, which is a finding that's been reported previously in Canada. And this could be due to difficulty accessing care, socioeconomic factors, education, lifestyle choices, much like the variables that are associated with an increased risk of dental caries in any of the population. We found a slight positive correlation between body mass index and DMFS score, as well as the number of anterior extractions. We expected, the first finding is what we expected to see, given that obesity and dental caries share so many of the same risk factors. So it would make sense that we'd see a higher BMI Z score with a higher level of decay. The increased number of anterior extractions could be related to the use of a bottle at nighttime from an early age, especially if the bottle contains sugar liquids like milk or juice. Frequent exposure to carbohydrates would decrease salivary production, which happens at nighttime when we go to sleep, has known to increase the risk for decay. And that same increase in sugar intake could be related to a child's risk of obesity. And a bottle certainly would focus the sugar on our front teeth. Conversely, we see a slight negative correlation between body mass index and the need for posterior extraction. The pulp-involved teeth in the posterior dentition could make it more difficult for a child to chew, as our molars are generally our grinding surfaces, which could increase or result in a decreased oral intake. Over time, the lower caloric intake could contribute to weight loss and an overall BMI that was lower, or in the case of children with normal weight status, just prevention of an increased weight gain. And boys were found to have significantly higher DMFS scores than girls. This finding is actually different to what's reported in the literature. Most of the literature reports that have a higher rate of decay. Caries risk factors for women often include salivary composition and flow rate, hormonal fluctuations, dietary habits, genetic variations, or particular social roles in their family. And again, individuals of registered First Nation status may be presenting with higher DMFS scores and more teeth of pulpal involvement due to socioeconomic status, education level, or difficulty with access to care. Does that just mean someone entered? Okay, just wanted to check I wasn't missing a question. Our study found that having family income of less than 28,000 was significant when considering body mass index, but not DMFS score. We also found that parental level of education was negatively associated with both BMI Z score and DMFS, and children of parents with higher education were found to have a lower BMI Z score and lower DMFS score. Both of these findings have been well reported in previous studies. As a whole, our study findings report the idea that children with severe early childhood caries in a developed Western society may be more at risk for obesity or an elevated BMI. However, knowing that both obesity and dental caries are multifactorial diseases, we really need to consider controlling for a lot of these confounding variables to evaluate whether there's a true relationship between these two diseases. Having this information in hand could be helpful in development of educational materials for physicians and dentists alike, to keep in mind when planning oral health and diet conversations with parents. Now, this study certainly does not go without its limitations. One of the largest limitations is that the Misericordia Hospital in Winnipeg limits the elective dental surgery procedures to children with BMI Z scores that are between -3 and +3, which automatically excludes any extremes in BMI, so whether severely obese or underweight. That could have potentially been related to the severity of DMFS scores. And these patients instead have to be seen at the Children's OR at the Health Sciences Center in Winnipeg. Determining DMFT and DMFS scores based on operative reports certainly can overestimate the extent of decay present, specifically when we're counting a stainless steel crown as 5 surfaces. However, we are taught that having treatment under general anesthetic alone is an indication to perform a stainless steel crown procedure, because we want to avoid having these kids going for a additional surgery to have more dental work done in the future. There has also been increasing popularity for dentists to use methods of indirect pulp tapping. So what this means for those of you that are not so necessarily dentally inclined is we avoid exposing the nerve of the tooth and put a medicament on top of the caries and try to seal it in to keep the tooth as vital as possible. And this can influence having the option to do this procedure can influence some of the dentist's decision-making when determining how to manage potentially nerve-involved teeth. And some people may be more inclined to leave decay in that area instead of performing a pulpotomy or removing the tooth, which would not necessarily be reflected in our operative report that we would have access to. This study certainly is also lacking a control group as a direct comparison, because we didn't have any caries-free children, but they wouldn't be in our sample size because they wouldn't be treated for severe early childhood caries at the Misericordia. Another limitation is, given the fact that we know both obesity and severe early childhood caries are multifactorial diseases, a key piece of information we're missing is oral hygiene practices at home. So we don't have information on toothbrushing or oral hygiene habits in these patients. They could be using fluoridated toothpaste at home or fluoride rinses that may have helped control the extent of some of their decay, or perhaps they had silver diamine fluoride, which is a medicament applied to teeth that can help arrest decay. If that was applied leading up to the surgery date, that may have limited the extent of their decay that was seen. Or if they're seen regularly for fluoride varnish application, that can change things as well. Some of these kids may also have healthy home habits in terms of diet, but without removal of plaque, they'd still be more prone to oral diseases like caries and periodontal disease, which could certainly disrupt any relationship that we might expect to see. Our study also lacks information about dietary habits like juice consumption and the use of a sippy cup or bottle at nighttime that would certainly implicate the development of severe early childhood caries with increased exposure to sugar. So there's definitely lots of factors to consider there. As I mentioned, we would benefit from an analysis that considers possible confounding variables involved in this multifactorial disease. So we have plans to use a multiple regression analysis to look at these variables a little bit closer. Also, as part of the larger project, families completed a NutriCheck questionnaire that evaluated the child's nutritional intake and daily activities. It could be interesting to consider the relationship of BMI and dental decay rates with some of the parental responses to things like difficulties with eating, swallowing, or chewing. We also have access to some of the post-surgery data from a 3-month follow-up as part of the larger study, and we may be able to evaluate some of the possible changes in BMI score that we're seeing post-surgery, and whether there's been an improvement to a more healthy BMI score after they've had their dental disease treated. So with the hopes of leaving you with a bit of a take-home message, I would like to provide you with a list of suggestions. Many of you, I'm sure, are fully aware of these, that a dental professional or non-dental professional can do to help educating families about diet as it relates to caries and obesity as a whole, and trying to encourage more activity. Don't forget that although there are multiple risk factors at play, regardless of what their weight was in this study, all of the kids that were seen in this study had severe early childhood caries and would benefit from some of this education. Lifestyle changes can be a hard thing to implement, so having the right attitude can make a big difference. Some of these are sensitive subjects in the homes, but dietary changes can impact more than just the child sitting in your chair. Sometimes it's a change that needs to happen in the whole family. It can be more effective to have a discussion and engage in conversation with the parents than talk at them. I know I'm at fault of doing this a lot. I can talk a lot and just ramble on to a parent, but not engaging them in the conversation makes it a lot easier to know that they're actually listening to some of the suggestions you're providing. People tend to respond better to positive suggestions rather than don't do this. So making sure that they know things that are helpful resources or alternatives to some of the habits that they need to change. And empowering parents to identify some of these barriers can make them more inclined to listen to your suggestions. So definitely, this is one that we say over and over, but encouraging a visit to the dentist at 1 year old. It doesn't have to be a big event, but a quick lap exam, just to look at the teeth and the gums, allows dentists to start the conversation with parents and provide oral hygiene and dietary recommendations just as teeth are first starting to erupt. Anticipatory guidance here is key, and the Manitoba Dental Association does support under 3 first visit free, so definitely encouraging families to get out to see a dentist. Making changes can certainly be overwhelming, so starting with 1 recommended home change at a time. So for example, if toothbrushing isn't happening at home, as well as a sugary diet and lots of juice in a bottle and no fluoride, pick 1 thing or 2 to focus on in between visits so it's not too overwhelming for a family to change. For example, you can first try to encourage daily toothbrushing and maybe change what's going into the bottle at nighttime rather than asking them to include fluoride on their toothbrush and stop taking a bottle at night. The American Academy of Pediatrics nutrition community recently reconfirmed that 100% juice and juice drinks have no essential role in the healthy diet for children and contribute to excessive caloric intake and risk of dental caries. And they recommend that limiting juice to 4 to 6 ounces per day as part of a meal or a snack. A lot of parents have a hard time getting their kids to kick the habit of drinking juice. So flavored drops of like Neo water or Crystal Light drops that have sucralose instead of sugar can be a good alternative to at least encourage their children to drink less sugar-based drinks, but still have a bit of flavor. The American Academy of Pediatrics recommends 4 ounces for children 1 to 3 years of age, 4 to 6 ounces for children in 4 to 6 years of age, and only 8 ounces for children that are 7 to 18 years of age, all in an open face cap, so avoiding using a sippy cup or a bottle. People are very familiar with the term baby bottle tooth decay, and most commonly associated with babies that have a bottle to bed at nighttime. But if that bottle of decay only contains water, it won't cause decay. So parents may express that they've had difficulties stopping the bottle at nighttime, and understandably so. It's not something that can happen all at once overnight. Having realistic expectations for your patients so they can have realistic expectations for themselves is really important. Working on diluting milk with water can be helpful. So starting, for example, with a bottle that's 3/4 full of milk and then adding 1/4 of water and gradually diluting it further over a 4 to 6 week period can make a huge difference. It doesn't work for everyone, but it's a hopeful starting point. And this is just a visual schematic to help demonstrate how you can effectively dilute a bottle of milk over a slow period of 4 to 6 weeks. Again, it doesn't have to happen overnight, and kids will either start hopefully accepting water at nighttime, or may just turn away from the bottle altogether, which in itself isn't necessarily a bad thing either. Providing families with healthy snack options like cheese, for example, it increases their salivary flow and helps our teeth keep naturally clean. Nuts are also a great snack that help fill us up and don't have the same cariogenic risk. It can also be helpful to advise parents which foods can be cavity causing. It's not just candies and chocolates. Raisins, for example, sound like they could be healthy, but they're very sticky and like to stick into the grooves of our teeth. A lot of parents think that juices that are all natural and don't have sugar added are healthier for their teeth, but they certainly have a higher amount of acid and sugar in them than water and do put us at risk of higher decay. Talking to kids about what activities they like to do outside can be a great way to encourage physical activity. Encouraging families to participate in community events is a great way to keep everyone active. In Winnipeg, for example, during the summer months, there's always things happening in Assiniboine Park. It could be very easy to share that information in your waiting rooms or with a what's happening in town board and try to get families engaged with things happening in the community. And something I more recently learned about was considering what your social media presence looks like if your office is online. That's a great place to share helpful suggestions with families, but we also need to consider what other people are posting online and what your patients and community members have access to. I recently went to a presentation where the physician speaking recommended Googling the most common answers you're asked in practice. So you can arm yourselves with the tools to answer a few more of the misnomers that patients may stumble across when asking Dr. Google instead of Dr. Dentist. And whether it's good or bad information that you're looking at, it can be helpful to guide your conversation with parents. So just a few examples of this. I recently looked at toothbrushing for kids, and it came up with some fantastic YouTube resources for videos and songs that might encourage kids to brush their teeth and make it more exciting. There's a couple of key Colgate articles. We know Colgate is a toothpaste brand, as well as a few great suggestions for making toothbrushing fun. However, there is also the reverse side of that, where we stumble across some very misleading information very easily. If you notice, I don't know how well you can read these screens, but none of these articles are actually from a particularly reputable source. All are posing fluoride as a poison when we know, in fact, we know that in the right dose, it's so helpful for our teeth and in its prevention of decay. So it's just a good idea to keep in mind what's out there and what information our patients can find, so we know what they're being exposed to, and hopefully we can help redirect them to some useful resources at home. So this nears the end of me babbling on about tooth decay and fluoride, and just about wraps up my presentation for today. So just some acknowledgements to say thank you for the people and organizations that help make this study possible, and some of the references. And we have some time for questions if anyone has any.
So maybe going to our folks from telehealth first, if anybody has questions. I think you can all unmute yourselves if you need to, because I think we had given you advice to mute yourselves before. So feel free to ask questions. It's work in progress, but thank you very much, Tara, for a great presentation. So I guess one of my questions is with BMI cutoffs, sort of for the Misericordia Health Center, sort of, so Tara, you're in a program, so you're going to different facilities. Do you know, is that sort of the norm, sort of cutoff for a sort of non-free facility, sort of a cutoff of, or within -3 to +3 BMI range?
From what I'm aware of, that tends to be the standard cutoff, because below -3, they're often failure to thrive or have difficulties gaining weight, and their other systems in their body are more compromised when they're at that low rate. Same thing with the higher weights above 3. It's generally considered above severe obesity, so they often have other confounding factors that have led them to be that weight.
And so it's more a safety issue that the anesthetists, they would have no problem sort of doing surgeries on children outside of those boundaries, but because it's not attached to a children's hospital.
Right.
Okay.
It's just more of a safety factor.
And I sort of just wonder with, I think Flin Flon's on the line and Thompson there and Churchill too, so there is probably pediatric dental surgery. I know there's pediatric dental surgery done in those facilities, and just sort of curious to know if those parameters are used to sort of identify suitability for cases for surgery in your facilities.
Hi, it's Joanna in Flin Flon. I'm actually the community dietitian, so I don't work in facilities, so I'm not really sure what their parameters are. This is Thompson. Although I do work with the Northern Consultation Center, which they do provide dental surgeries through there. I couldn't speak to it. Again, I'm a dietitian as well, so we're all dietitians here in our room.
That's great.
So,
that's great.
Yeah.
And any questions on nutrition that you'd like to pose? We welcome feedback too on this type of project. I know there's a lot of interest. Our group has been working in this area for a few years, looking at sort of these connections between health and well-being and oral health in young kids. And so we have others looking at quality of life. Tara's looking at BMI. And with this study, we're also looking at vitamin D and iron levels to see sort of if there's improvements after surgery. Sort of with this study, there's the ability to sort of look after sort of surgery for changes, but I know we've talked a little bit about it, but your sort of thought after this observation period, likely we wouldn't necessarily see changes.
It would be unlikely in a 3-month follow-up period to see an immediate change in BMI. I think it's more of a long-term health change that we have to see in diet and activity that would result in that.
Yeah, we definitely appreciate it, and we are definitely looking forward to seeing the results of the study. I think iron deficiency anemia, severe early childhood caries are all issues we deal with quite frequently here, so it will be interesting to see.
Perfect.
Great, thanks.
How about we go to Zoom, Tara and Tiffany? Any questions there posted by anybody joining us by Zoom?
Nope, I don't see any written there.
Any other questions from those joining us today? Looks like someone was there from Hollow Water, is that right? Yeah, so one from Hollow Water will mark you down. So that's great.
Thanks for the presentation. Thank you for the presentation.
Perfect. Any questions at all?
No, I'm a public health nurse. I can really identify with trying to, the whole sippy cup thing. Everybody gets the information, and I agree with you about talking to people. I think I'm probably guilty of that. I talk to people as opposed to with people. Sometimes I try not to, but yeah, anything to get some change would be, you know, it's a struggle sometimes. So. But thank you for the presentation.
Perfect. Thank you. So Daniela, first of all, we want to thank Tara for joining us today. If there are other questions, by all means, chime in. But Daniela, do you want to maybe give us a caption sort of upcoming topics, when our next telehealth session is likely scheduled?
Yeah, we have one that's scheduled for November, I believe, and it is Dr. Kalia Hai Santiago, and she will be presenting on fluoride, water, like fluoride in water, and also fluoride in toothbrushing. So I will be sending out more information about that shortly.
October 11th.
October 11th. October 11th.
And then we'll be having an upcoming one as well on silver diamine fluoride as a new way to manage caries in young kids, as a way to potentially maybe avoid the need for a trip to the operating room. Doesn't necessarily mean avoiding any treatment, but maybe to delay till kids are a little bit older, till they can be treated in the chair. And we've got results from one of our trials here. And then, of course, we would then, once we have available our data on iron and vitamin D status and changes in those outcomes in children, we can definitely arrange a telehealth session for that.
Yeah, and just a reminder to everybody, because it's very helpful for us, just to get the participation list filled out and sent back to us, as well as the feedback forms. And if you don't have them, just to contact us and we'll send them out to you. And, you know, any other topics that you are interested in that you'd like to see, please let us know.
Great. Thank you, everybody.
Thank you. We'll end now.
Being told I was doing SDF in the fall, September, October.
October 11th.
No.
It's
I just
the
wanted
latest.
to just-
So do you want to do one before? Like that's what I just